You're about to hear something that most people never realize until it's already too late. A 7-8-year-old man walked into a clinic for what should have been the simplest thing in the world, a routine checkup. He wasn't fragile. He wasn't struggling. He walked 3 miles every morning without fail. He lived alone, took care of himself. Sharp mind, strong body, completely independent. And then everything changed. One test led to another, then a referral, then a procedure, then a complication no one had planned for. 6 months later, the same man who once walked miles every morning couldn't even make it to his own mailbox. Here's the part that should stop you cold. The original issue? It was never going to harm him. The test did. This is where the story most doctors don't tell begins. Because something quietly shifts as you age, and almost no one explains it clearly. The rules you live by in your 40s and 50s, they don't work the same way in your 70s and beyond. But medicine hasn't fully caught up to that reality. For decades, we've been taught that early detection is everything. Find a problem early, fix it quickly, and you extend your life. That mindset makes perfect sense when you're younger. It saves lives. It absolutely does. But here's the uncomfortable truth most people never hear. The exact same test that could add 20 healthy years to a 50-year-old's life might only add a year or two for someone in their late 70s. And those extra years, they may not be spent living freely. They might be spent recovering, managing side effects, dealing with complications that never needed to happen in the first place. That's not fear-mongering. That's reality. And yet, every single day, millions of older adults walk into clinics and walk out with referrals for tests based on guidelines that were never designed for their age group. That's where things start to go wrong. Because once a test finds something, even something small, harmless, or slow-growing, the entire system shifts into motion. Doctors feel pressure to act. Patients feel pressure to say yes. And suddenly, a perfectly healthy person is lying on an operating table for something that may never have affected their life at all. This is what's known as the cascade effect. And once it starts, it's incredibly hard to stop. It doesn't begin with something dramatic. It begins quietly. A routine scan shows something borderline. Let's just take a closer look, they say. That closer look finds something else. Now you need a biopsy. The biopsy causes a minor complication. That complication needs monitoring. The monitoring uncovers another issue. Now you're on medication. The medication causes side effects. The side effects lead to something new. And before you even realize what's happening, your life has changed. Not because of a disease, but because of the process meant to protect you. This isn't rare. It's not hypothetical. It happens far more often than people realize, and it's almost never part of the conversation when a doctor recommends a test. That's the real problem. You're being asked to make decisions without being given the full picture. So today, we're going to change that, because there are specific tests commonly recommended, routinely ordered, that deserve a second thought after a certain age. Not because they're bad, but because the balance between benefit and risk quietly shifts, and no one stops to explain when it does. What if one of the most routine procedures in modern medicine wasn't as routine for you anymore? Let's talk about something. Millions of people over 70 are still being scheduled for every single year, almost automatically. A colonoscopy. Now, to be clear, this test has saved countless lives. For people in their 50s and early 60s, it's one of the most powerful tools we have. It detects polyps early, removes them before they become dangerous, and significantly reduces the risk of colon cancer. That's not up for debate. But here's where things start to shift. Quietly, and without much discussion. After the age of 75, the equation changes. And most people are never told how. Because colon cancer doesn't usually appear overnight. It's slow, incredibly slow. In most cases, it takes 10 to 15 years for a small, harmless polyp to develop into something dangerous. Think about that timeline for a moment. If you're 76 years old today, and a colonoscopy finds a small polyp, what are the realistic chances that polyp will ever affect your life? For many people, the answer is very low. Not zero, but low enough that it changes how we should think about the test itself. Now here's the other side of the equation, the part almost no one explains in detail. The procedure isn't risk-free, and those risks increase with age. It starts before you even enter the clinic. The preparation, the intense bowel cleanse the night before, is not just uncomfortable. In older adults, it can lead to serious dehydration and dangerous electrolyte imbalances. That's not just inconvenient. That can become a medical issue on its own. Then comes the sedation. As we age, our bodies process anesthesia differently, slower, less predictably. What used to be a quick recovery can sometimes lead to confusion, disorientation, or even lingering cognitive effects. Some patients bounce back quickly, others don't. And then there's the procedure itself. A colonoscopy involves inserting instruments into the colon. In younger patients, complications are rare but manageable. In older adults, especially those who are more fragile, the risk of perforation, a tear in the bowel wall, becomes significantly more serious. In some cases, life-threatening. So now you have to ask yourself, something most people never think to ask. What happens if we actually find something? Because that question changes everything. If the answer is, we'll monitor it, but likely won't do anything aggressive, then why go through the risks of the procedure in the first place? This is exactly why guidelines have evolved. Medical organizations now recommend that colonoscopy after 75 should not be automatic. It should be individualized based on your overall health, your life expectancy, and your personal preferences. But here's the reality inside most exam rooms. That conversation often doesn't happen. Instead, a referral is handed over like it's just another routine step. No pause, no discussion of trade-offs, no explanation of how the math has changed. And that's where you need to step in. Because this isn't about rejecting care. It's about making informed decisions. It's about understanding that what was once clearly beneficial may now require a deeper look. So the next time a colonoscopy is suggested, ask one simple question. If you find something, what are we actually going to do about it? That one question forces clarity. It slows the process down, and it gives you back control over a decision that directly affects your quality of life. Because the goal isn't to find every possible abnormality. The goal is to protect your life as you're actually living it. And sometimes, that means knowing when not to look. Few words trigger more fear, more urgency, more instinctive action than one word. Cancer. The moment it's mentioned, everything else fades into the background. Logic takes a back seat, emotion takes over, and the immediate thought is almost always the same. Find it early. Do something. Anything. That instinct is human. It's powerful. And in many cases, it's absolutely the right response. But here's where things become more complicated, especially after the age of 70. Because finding cancer and helping a patient are not always the same thing. And that distinction? It's rarely explained clearly. Let's start with something incredibly common. PSA testing. A simple blood test used to screen for prostate cancer. It sounds harmless, routine, responsible. And in younger men, it can be. But in men over 70, PSA testing often detects something very different from what people expect. Slow-growing cancers. Cancers that may never cause symptoms. Cancers that, in very real terms, a person may live with for years without them ever becoming a threat. There's a phrase doctors sometimes use quietly and not often enough in front of patients. Cancers you die with, not from. Now think about what happens next. The test comes back elevated. That number alone creates anxiety. Now you're scheduled for repeat testing. Then, a biopsy. The biopsy itself isn't risk-free. There's a chance of infection, bleeding, and significant stress. But even beyond the physical risks, something else happens. Once cancer is confirmed, even if it's slow, even if it's unlikely to progress, the pressure to act becomes overwhelming. Surgery, radiation, hormone therapy, each one comes with consequences. Loss of bladder control, sexual dysfunction, chronic fatigue, bone weakness, and all of this for a cancer that may never have affected your life. This is exactly why major medical guidelines now recommend against routine PSA screening in men over 70. Not because prostate cancer doesn't matter, but because, at that age, the harm caused by finding and treating it can outweigh the benefit. Now, let's shift to something just as common: mammography, breast cancer screening. Again, incredibly valuable in younger populations, no question about that. But after 70, the same pattern begins to emerge. Many breast cancers detected at this stage are slow-growing, hormone-sensitive, and unlikely to spread aggressively. Yet once they're found, the system responds the same way. Surgery is recommended, often followed by radiation. No, sometimes chemotherapy. And here's what that can look like in real life. A woman in her late 70s, living independently, managing her daily life with confidence, suddenly finds herself going through months of treatment, surgery, recovery, pain, fatigue, limitation. A full year of her life consumed by something that, statistically, may never have caused her harm. This is not about dismissing cancer. It's about understanding context. Because yes, some cancers after 70 are aggressive. Some absolutely require treatment, but many don't. And the only way to know the difference is to have an honest, individualized conversation before the screening even happens. Not after, before. So here's the question that changes everything. If this test finds something, what will the treatment actually look like for someone my age? Not in general, not in theory. For you. Because the answer to that question might be very different from what you expect. It might involve trade-offs you haven't considered. It might reveal risks that were never mentioned. And most importantly, it might give you the clarity to decide whether screening is the right choice for you or not. This is what informed care looks like. Not fear-driven decisions. Not automatic referrals, but thoughtful, personalized choices based on what truly benefits your life. Because at this stage, it's not just about adding years. It's about protecting how those years are lived. Let me ask you something. Have you ever been told to just do a stress test, even though you felt completely fine? No chest pain, no shortness of breath, no dizziness when walking, nothing that suggested your heart was in trouble. And yet, there you were, walking on a treadmill, wires attached to your chest, or lying still, while medication pushed your heart to simulate exercise. At the time, it probably felt responsible, proactive, smart. But here's what most people over 70 are never told. If you don't have symptoms, that test might be opening a door you never needed to walk through. Because cardiac stress testing in asymptomatic older adults comes with a problem that doesn't get talked about enough: a high false positive rate. That means the test often flags something that looks like a serious issue, but isn't actually causing harm. And once that flag appears, the next step is almost automatic. More testing, more imaging, and very often cardiac catheterization. Now, this is no longer a simple test. This is a procedure where a thin tube is inserted into your arteries, usually through the wrist or groin, and guided toward your heart to get a closer look. It's precise, it's powerful, and in the right situation, it's life-saving. But it also carries real risks: bleeding, damage to the artery, kidney strain from the contrast dye, and in rare but very real cases, a stroke during the procedure itself. These risks are not theoretical, and they increase with age. Now here's the part that should make you stop and think. Large, well-conducted studies have shown something that challenges everything most people assume about heart procedures. In patients with stable coronary artery disease, meaning no active symptoms like chest pain, procedures like stenting or bypass surgery did not reduce the risk of heart attack or death compared to managing the condition with medication alone. Let that sink in. For people without symptoms, opening the arteries surgically did not lead to better long-term outcomes than simply taking the right medications. Same outcomes, two very different paths. One involves invasive procedures and recovery. The other doesn't. So why does this matter so much? Because once a stress test shows something abnormal, the momentum builds quickly. It becomes very hard to step back. You're told, "We found something," and naturally, your instinct is to fix it. But the truth is, what's being found may not be dangerous in the first place, and the act of trying to fix it may expose you to risks that outweigh the benefit. This is where the cascade effect becomes especially powerful. One test leads to another. That leads to a procedure. And suddenly, you're in a catheterization lab. Not because you felt unwell, but because something showed up on a screen. So what should you focus on instead? The things that actually have decades of evidence behind them. Managing your blood pressure, keeping cholesterol under control, staying physically active in a way that fits your body, avoiding smoking, maintaining a healthy weight. These are not dramatic interventions. They don't involve operating rooms or advanced equipment, but they work. And most importantly, they don't carry the same risks as invasive procedures. This doesn't mean stress tests are useless. Far from it. If you have symptoms, if you're experiencing chest discomfort, shortness of breath, or unexplained fatigue, then these tests can be critical. But without symptoms, that's where the conversation needs to change. So the next time a stress test is suggested, pause for a moment and ask, what are we looking for? And what happens if we find it? Because if the answer leads down a path that doesn't actually improve your outcome, you deserve to know that before you take the first step. Let's talk about something that sounds simple, almost harmless. And yet, for many people, over 80, it can quietly lead to decisions that carry far more weight than expected. Bone density testing. You've probably heard of a DEXA scan, a quick, non-invasive test that measures how strong your bones are. No pain, no recovery, no obvious downside. On the surface, it seems like the perfect screening tool, and in many cases, it is. But here's where things begin to shift again, not in the test itself, but in what happens after the results come back. Because if you're over 80, and that scan shows low bone density osteoporosis, the next step is often automatic. A prescription, usually a class of drugs called bisphosphonates. Now, these medications are not inherently bad. In the right patient, at the right time, they can reduce fracture risk by slowing down bone loss. But in very elderly adults, the situation becomes more complex. Because these drugs don't just affect bone, they affect the entire system. Some people develop significant gastrointestinal issues, irritation in the esophagus, difficulty swallowing, discomfort that can turn a daily routine into a constant reminder of treatment. And then there's something even less discussed, a rare but serious condition known as an atypical femoral fracture. This is where the thigh bone, the strongest bone in your body, can actually break. Not because it's weak, but because the natural process of bone renewal has been suppressed for too long. In other words, a medication meant to prevent fractures can, in rare cases, contribute to one. Now pause for a moment, because this is where the real question begins. What actually prevents fractures in older adults? Is it the number on a scan, or is it something else entirely? The research is remarkably consistent and surprisingly straightforward. Falls cause fractures, so if you prevent the fall, you prevent the fracture. And how do you prevent falls? Not with a prescription alone, but with strength, balance, environment, simple, practical changes that directly impact how you move through your daily life. Muscle strength training, even light resistance exercises, can dramatically improve stability. Balance work reduces the risk of sudden missteps. Reviewing medications that cause dizziness can eliminate hidden risks. Improving lighting in your home makes hazards visible. Installing grab bars in bathrooms, using non-slip mats. Making sure your floors are clear and safe. These interventions don't show up as numbers on a report, but they save lives. They preserve independence. They keep you moving confidently in your own space. And yet, they're often treated as secondary. Because a scan produces a number, and a number leads to a prescription. It feels concrete, actionable, immediate. But here's the truth most people never hear. A DEXA scan won't tell you to install a grab bar. It won't remind you to strengthen your legs. It won't evaluate how safely you move through your own home. It gives you data, but not necessarily the solution that matters most. So if your doctor recommends a bone density scan, the conversation shouldn't end with the result. It should begin there. Ask this: what are we doing to reduce my actual risk of falling? Not just, what medication should I take? Because the strongest bones in the world don't matter if the body controlling them isn't stable. And after 80, stability becomes everything. This doesn't mean medication is never appropriate. It means it shouldn't be the first and only response. It means the focus should shift toward what truly protects your independence. Because at this stage, the goal isn't just stronger bones. It's a safer, more confident life. Now, let me paint you a scenario. You're 74 years old. You feel completely fine. No dizziness, no weakness, no warning signs. And yet, during a routine visit, your doctor orders a scan of the arteries in your neck. You don't think much of it, it seems. Precautionary, responsible, until the results come back. And suddenly, everything changes. The scan shows a 70% blockage in your carotid artery, the vessel supplying blood to your brain. Suddenly, there's urgency, a specialist, a recommendation for surgery. But here's what most people are never told. Clearly, if you have no symptoms, the benefit of surgery is uncertain. In fact, Studies show the risk of stroke during the procedure can equal or even exceed the risk of leaving the blockage alone. So the very surgery meant to protect you could harm you. This is why major guidelines advise against routine screening in symptom-free patients. And yet it still happens. So what should you do? Shift your focus. After 70, real medicine isn't about chasing every abnormality. It's about protecting your independence, your clarity, your ability to live fully. Control blood pressure. Stay active. Review medications. Protect your balance. Ask better questions. Because everything changes with one simple sentence. What happens if we do nothing? That question gives you back control. If this opened your eyes, share it with someone who needs it, and subscribe for more conversations that most people never get to hear.